It's so nice to see you.
You can start.
Ma'am, can we start now?
Yes, I think Dr. Picky, I think we should start. Reena ma'am का क्या है?
डॉक्टर रीना बीच में ज्वाइन कर लेंगे. आई थिंक वी कैन स्टार्ट. लेट्स नॉट वेस्ट टाइम because
ठीक है, Megha, we
I've
can
also
start.
not reached home. I think we
Yes,
should
ma'am.
start. Yeah.
So, good evening.
So, very good afternoon, everyone. Thank you all for joining this webinar on topic PCOS, a 360-degree clinical update, which is organized by IFS and subcommittee AOGD. I would like to express my heartfelt gratitude to AOGD and IFS Infertility and Reproductive Endocrinology subcommittee of AOGD for giving me this golden opportunity at this platform, for inviting me as a MOC. Now, I would like to invite Dr. Picky ma'am. Picky ma'am is director professor, and she is heading a department of IVF. She is highly dedicated, and she is hardworking in the field of IVF, reproductive medicine. Welcome, ma'am.
Dr. Niti, we couldn't see the CV. Dr. Picky, आप start करिए.
Hello everyone, a very warm welcome to you on behalf of I'm the chairperson of the Infertility and Reproductive Endocrinology Committee of AOGD and also the convener of Special Interest Group of Early Pregnancy of the Indian Fertility Society. So this is a very focused meeting taking into account the 360-degree clinical update. And along with me, I have my co-convener of the SIG Early Pregnancy, Dr. Bindu Bajaj, who is heading the Department of Obs and Gynae at Safdarjung Hospital. And my co-convener is Dr. Niti. Dr. Niti Tiwari is the convener of the PCOS committee of Indian Fertility Society. And also we have Dr. Deepa Gupta, who is the chairperson of the Community Health and Awareness Public Health Awareness Committee of AOGT. So this is a very, very important and focused PCOS meeting on PCOS. And we have a very special guest with us, Dr. Abhyuday Verma. We welcome you here today.
Thank you, madam.
Meeting, we wanted to have the inputs from experts from gynecology, general gynecology, infertility, and also we have Dr. Abhyuday, who is the endocrinologist and who is going to share his point of view and give us some clinical insights. So I welcome all my dear friends, and I can see Dr. Rakhi, Dr. Jyoti, Dr. Meeta. I think I should not take names of everybody. And I think, has Dr. Reena ma'am joined? I can't see ma'am. Dr. Deepa, I'm joining from my mobile. Can anybody see Dr. Reena ma'am? She's the chief guest. Yes?
No, ma'am is not there.
No, we can't
Okay,
see
so
her,
Dr. Reena will be joining soon. Madam is the head of the Department of Obs and Gynae of Lady Harding Medical College, and she's also the president of AOGD at present. She's a very keen endoscopic surgeon, and as she joins, we will introduce her further. And I now want to hand over to Dr. Deepa Gupta, who is the chairperson of Community Health and Public Awareness Committee, and she can say a few words.
Yeah. Thank you, Dr. Picky. And thank you, AOGD team and IFS team for including me. And I welcome you all. It's a proud privilege for us. The Madhya Pradesh Society of Obs and Gynae and Delhi Society of Obs and Gynae are together for a very, very insightful talk and panel. And I just want to say one thing. I'm contesting for ISOG Governing Council, so I will need a very precious vote for all of you and guidance from all. And we have Dr. Rakhi Singh ma'am, who is contesting for Vice President North Zone. So the elections are supposed to start from tomorrow. So she needs blessings from all of us and all the support from all of us. And we have Dr. Shashibala Bhonsle, who is also contesting for ICOG Governing Council, and Dr. Shweta Kaul, who is contesting for a committee chairperson. So welcome you all. Not wasting much of time. Now I will hand over the mic to Dr. Niti Tiwari, who is a convener, IFS, and IVF specialist in Sir Gangaram Hospital.
Just a second. All the best to all the 4 contestants. I did not know 4 people are there contesting for elections here. So wishing you all the very best. And Dr. Raki is a very close friend. And she's a very, very capable person. And we will know more about her. She's contesting for the post of Vice President. Dr. Deepa, Dr. Shashibala, and one more person.
Dr.
They are
Shweta
contesting.
Kaul. Dr. Shweta Kaul for Chairperson Modern Technology in OBGYN.
Thank you, Vicky. And thank you, Deepa.
Thank you, Piki ma'am.
And
Thank you.
Dr. Neeti. Yeah.
Thank you, everyone, for the best wishes. In fact, I am IFS member since the 2017. So,
Okay, great.
so I'm
Great.
also a member of your thing. All the best, Raki,
Thank you, Shashi.
Shweta, and Deepa.
Thank you,
Thank
Shashi.
you, madam. Thank you, madam.
Thank you, madam.
Yeah.
Jyoti
Yes.
madam is here. I just want her blessings.
Definitely, for all the 4 contestants, all the best. And
Thank you.
this platform is going to be a proud platform.
Thank you,
Thank
Dr.
Yeah,
Deepa.
yes, we have got very 2 prominent faculty here. Dr. Jyoti Bhaskar ma'am, she is Delhi chapter Indian Menopause Society president, and Dr. Abrijbala Tiwari ma'am, she is chairperson FOXY and Environmental Committee. We welcome you, ma'am. Over to you, Dr. Niti.
Good afternoon, everyone. It's a proud privilege today to address a nice gathering, and all the best to all the contestants. All our wishes are with you, and all our support are with Rakhi Singh ma'am and Dr. Deepa Gupta, Dr. Shashibala Bhosle, and Dr. Shweta Kaul. Our best wishes to all of you. So I bring greetings from a special interest group, PCOS. We keep on holding webinars which are pertaining to only PCOS in different populations. And I thank Dr. Piki Saxena for giving us this opportunity to collaborating with her in this webinar today. So we're looking for a good academic program. All the best. Thank you.
Dr. Bindu, would you like to say a few words?
Thank you so much, Dr. Picky. I mean, I think I have hardly contributed this time. I was too busy with my own problems, and I wish them all well, all of them who are contesting, and I can assure you that we are all with you, and best of luck.
Thank you.
Thank you.
Thank you.
Over to Dr. Megha to start the scientific program.
Yes, ma'am. So we'll start our webinar with session first. So I'd like to introduce our expert for this session, Dr. Abudya Verma. Sir is an endocrinologist. He is a consultant endocrinologist at Verma Hospital and Seva Endocrinology and Women Care Clinic at Indore, Madhya Pradesh. Sir has many publications in international and national journals. Sir, welcome, sir.
Thank you, madam. Thank you.
Then I'd like to introduce our chairperson for this session, Dr. Shweta Gupta. Ma'am is a director of IVF Max Super Specialty Hospital, Delhi, Noida. And she is a director, SG Clinic, Wave Center in Sector 32, Noida. Welcome, ma'am.
Thank you.
Dr. Megha, none of the PPTs are visible. Are you sharing your slides?
Ma'am, please share
Yes.
again. It's not sharing.
I
Not
have not
shared.
been able to see even one slide because that
Okay,
is how
ma'am.
we'll introduce everyone. Na? Even
Yes.
if we don't read out the whole, at least everybody will get an outlook of who is doing.
Now is
Yes,
it visible?
your slides are visible, right? Please put it on full.
Done. Good.
Yeah, yeah.
That's
That's good.
next time.
Next, I'll like to introduce Dr. Jyoti Bhaskar. Ma'am is additional director consultant Obs and Gynae at Cloud9 Hospital, Delhi, Noida. She has been Secretary, Delhi Chapter of IMS 2023-26, Member Executive Council of AOGD 2025-26. Welcome, ma'am. Now, I request Dr. Shweta Gupta to introduce our speaker, Dr. Rakhi Singh. Ma'am.
Mega, Dr. Deepika Verma और Dr. Parul Garg को नहीं आपने introduce किया.
Okay,
For the-
sorry, ma'am.
Yeah.
Dr. Parul Garg, ma'am, is executive member of IFS Society. She is heading a department of reproductive medicine at Artemis Hospital, Gurgaon. Welcome, ma'am. Dr. Deepika Verma, ma'am is a consultant gynecologist at Verma Hospital and Seva Clinic, Indore. Welcome, ma'am. Now I'll request Dr. Shweta Gupta to introduce Dr. Rakhi Singh, our speaker for this session.
Yeah, thank you, Dr. Megha, and thank you, Dr. Picky, and the whole organizing team for inviting me for this focused meeting. Can I have next slide of Rakhi? Yeah. So Dr. Rakhi, actually a very close friend, and we have seen her working not only at local level and also at a national level. She has been currently very dynamic president of Noida Obs and Gynae Society, also the governing council member of ICOG 2024-25. She is the vice chairperson of UP State SR, also peer reviewer of Journal of Obs and Gynae of India, also chairperson of Endocrinology Committee of FOXY 2020 to 23, where she has done a lot of publications, a lot of work on this field. And she had numerous awards, achievements, and publications, invited faculty for more than 300 national and international conferences, convener for FOXY, ICOG, GCPR, updated management of PCOS, editor of FOXY, Focus Harmony of Hormones, FOXY DC Datta Award she has received, publications 64 AICOG 2022, FOXY DC Dawn First Prize, written many chapters, received Wonder Voxidian Award, and also FOXY UNICEF Certified Trainer for Violence Against Women, Cancer Prevention. I know her personally. She has been very active member at Noida and also organized very recently very big scale conference, worked very hard, involved all the local, I think, people as well as the national level people. And we are very proud, and I'm very sure that she will do very well in this conference. Today, she's going to speak on a very interesting topic, and where I think she has put a lot of hard work also, and the topic is hirsutism. I remember she has come out with a algorithm which is so useful, and last time we conducted a whole panel on it. So over to you, Raki, and we are really looking forward for this very interesting topic and very good message. I'm sure it will have with all that algorithm which you prepared, which is quite useful, and I think it is there in Google as well.
Yes.
So over to you, Raki, here.
Thank you, Shweta. And at the outset, I'm thankful to AOGD and IFS for jointly conducting this SIG, the Special Interest Group webinar on PCOS specifically. And greeting and regards to Dr. Pankaj Talwar, Dr. Shweta Mittal, Dr. Reena Yadav, Dr. Ratna Biswas, Dr. Fiki Saxena, Dr. Bindu Bajaj, Dr. Neeti Tiwari, Dr. Deepa Gupta, all my dear friends and seniors and respected chairpersons over here, again, whom I admire, and a great friend, Shweta, Parul, Deepika, and Dr. Jyoti Bhaskar, another a great and a friend of mine. And as Shweta has told already, that PCOS is one forte which I like to speak upon every time. And today we are talking upon the focused approach for PCOS. But I would like to talk on something on PCOS that I would like to fondly compare PCOS with a tree. What we see in the tree is just the things what are just above the ground. The fruits, the trees, all those things are only seen. But whereas the things, the root cause of it, we don't see. Likewise, most of the patients, they go to the dermatologist nowadays to get the hirsutism treated, the laser treatment done, the acne treatment done. But the root cause they don't know, and they are not treating for that, which is very important. If you correct the root cause, that would be the best and do wonders for them. And as it is the PCOS, when we talk about the word androgen, which androgen is the excess in PCOS, which is derived from the Greek word andros and geos, which means a man to produce or create. Hyperandrogenism is therefore any state with an excess production of the male type of hormones, although these hormones are normally found in the woman at lower levels. The most clinical relevant hormone in the hyperandrogenism is the testosterone level, which is converted peripherally to dihydrotestosterone. It is a biologically active form of the testosterone which is seen. There has been numerous attempts to diagnostic criteria for these hirsutism and acne to be done in this PCOS. Let it be the NIH, let it be the Rotterdam's criteria, Androgen Access Society, the NIH extension with the ASHRAE or the ASRM. But one thing stays common in all the four of them, which is hyperandrogenism and oligoanovulation, which is common. But the third criteria which has been added with the Rotterdam's is PCOM morphology on ultrasound. But any two out of these three criteria, if it is positive, then we know that we are looking at a PCO patient very well. Just a brief overview. In all these PCO patients, there are 4 phenotypes. And as we go down from A to D, the difficulty and the problems encountered with these patients keep on decreasing. Whereas the A and the B phenotypes are very common. The C phenotype is less common and the D phenotype is much more less virulent and common. And in the C and the D phenotype, C we have hyperandrogenism with polycystic ovarian on morphology or ultrasound. But in D, there is only the ovulatory dysfunction and the polycystic morphology, but there is no other hirsutism or acne being there. Whereas in A and B, we find insulin resistance and glucose intolerance being very high. And these patients could be at risk for diabetes also. So because of which the acanthosis is also very common. And when we talk about the ultrasound in polycystic ovaries, there is a clear recommendation for the reporting platform for these patients. These are all the required conditions how we need to report if the ultrasound. And any patient which is had menarche post 8 years of menarche, up till 8 years, we are not supposed to report it as a polycystic ovarian patient. There we need to write down that multiple cysts in the ovary, we cannot label them as polycystic ovaries, and do report any other abnormalities which are seen along with the detection of PCOS. And the lab test, when we talk about all these, thyroid prolactin is one which has to be always done for these patients. Apart from that, FSH, LH, and serum AMH, which is optional, can be done. But the testosterone, free and the total is to be done. Free androgen index is to be seen. And ultrasound for the PCOM, the OGTT is to be done. But when we talk about AMH, the assessment is always not necessary. It can be clinical or biochemical hyperandrogenism, which can be present with irregular menstrual cycle, can be detected along with it. But when we are talking about the assessment complications, the androgen profile of this patient has to be ruled out. And we need to check for the excess of the androgen secretions. And do remember to ask if this patient has had the symptoms which are very fast in coming down, that is hirsutism is very fast in growing, then we know that we are not looking at PCOS. But whereas in 80% of the PCO patients, the hirsutism which is there is in PCO, whereas only 20% with a virulent increase, very fast, rapid hirsutism growth, we'll know that it is not the PCO patients. And when we talk about the free androgen index, which is more specific to measure for the free and the active testosterone, which is responsible for the hirsutism, and the total testosterone is calculated as amount of total testosterone into 100 gives us the androgen index, and which needs to be understood. There are very many cosmetic concerns of hyperandrogenism. Let it be the hirsutism or let it be the acne, which is stubborn for these PCO patients. And when we talk about clinical hyperandrogenism, hirsutism is seen to the tune of 60 to 80% of the PCOS, where there's excess amount of the hair growth over the body. Acne being the second most common sign, which is to the tune of 10 to 34%. Androgenic alopecia is also seen in these patients because of high testosterone, that is hair loss. Both the extremes are there in these patients of PCO, which is seen male pattern of baldness to the tune of 3 to 34%. And the prevalence of hirsutism in women with PCOS is between 70 to 80%. And the prevalence in the adult acne is around 30 to 40%, which is the first one in the list is around hirsutism, then comes the acne, and then comes the female pattern of hair loss, thereafter the acanthosis. And this is how the symptoms what we see. And any patient of PCOS, the symptoms of these patients, clinical presentation, scream loud at length to understand that this patient is having PCOS. Whereas any hirsutism patient, any hyperandrogenic patient would have body image issues. And because of the body image issues, because of the appearance of their body, these patients would definitely go into depression, anxiety, eating disorders, psychosexual dysfunctions, a negative body image thinking would be there. So we have to be very sensitive for these patients because it reduces the quality of life of these patients. And do remember to counsel them up and talk to them about the depression and anxiety, about their body image issues. As I had said earlier, the evaluation of this patient, the duration, onset of the symptoms have to be noted. Do remember to ask the irregularities in the menstruation, any drugs if the patient is on, and clinical evaluation has to be done, whether it is the slow onset or it is the rapid onset, that would give us at length. Let's understand and hear what the Bollywood celebrities or the Hollywood has to say about PCOS and their symptoms.
PCOS is a common hormonal disorder that affects 1 out of every
I'm sorry, I think my phone has, laptop has got hanged.
Atul, can you help ma'am in some way?
It's got hanged only. Not able to move anything. If you can hear me,
Yes, we can
Yes,
hear you,
ma'am,
ma'am,
so
but
just
can't
give me some time.
moving the slide.
आप एस्केप करके देखें उसके ऊपर
ये
ये
प्रेस कर
जब
रही
होता
हूँ,
है ना,
हैंग हो गया है मुझे लगता है.
आप उसको एस्केप करें पहले.
कर रही हूँ मैं. I'm doing that only. Let me do stop sharing and reshare it again. Just a second, let me off it from behind only, the presentation.
Close your presentation, then open again, then try.
आपको ऑफ भी नहीं हो रहा है, वो हैंग हो गया है somehow.
Ma'am, you can just click on the taskbar. Close from the taskbar.
कहीं से कुछ नहीं हो रहा भाई. भव्य ये देखना, ये हैंग हो गया ये. ऐसे आएगा. फिर क्या होएगा?
आपको बोलना है कुछ नहीं?
हाँ, ये चल भी नहीं रही स्लाइड्स. ये आज तक नहीं हुआ, पहली बार हो रहा है.
मैम ये रीशेयर हो पा रहा है क्या?
अरे वो कुछ भी नहीं बेटा, ये ऑफ ही नहीं हो रहा. रीशेयर तो कर दिया, इट इज गॉट स्टक. डिलीट कर.
Dr. Raki, if you have it on your phone, you can send it to someone and they can play it on the WhatsApp.
Yes.
Dr. Raki, you can WhatsApp it to me. मैं दिखा देती हूँ.
सेकंड. हाँ, तेरा दोनों उसी में प्रेजेंटेशन डाल करके लोड कर. पेन ड्राइव से डालूंगी. लेट मी जॉइन अदर लैपटॉप.
फिर से ट्राई कर लो. हाँ
हाँ, मेरा पर्स लेके आ बाहर से. इसमें ईमेल कौन सा डाला हुआ है? Let me share the link also. For the other, I have to log in again.
Amit, my video is disabled. Can you please let me be there on the window?
नहीं हो रहा है.
ये
वो ऑफ हो
Done,
जाएगी.
ma'am.
Okay.
डॉक्टर राखी, आप मेरे को भी भेज दो, मैं करती हूँ.
वही कर रही हूँ, मैं भेज रही हूँ अभी.
ठीक है.
When we see these girls at the age of 20, 24, and they come and say we have PCOS. So we are very fast in labeling a girl as a PCOS in the adolescent also. So as far as the whole criteria has
Correct.
changed, we have to think twice before labeling, because then they move around with that label lifelong and no one actually goes back to see whether they are PCOS or not. So we need to follow the particular criteria for diagnosis. I think Dr. Raki is back over here. So we'll go back to her lecture.
Sorry for all the.
PCOS is a common hormonal disorder that affects 1 out of every 10 women in the world.
Thank you.
What
Thank
is
you.
about
We
PCOS?
can see your
Several
slides.
celebrities from Bollywood and Hollywood have
Dr.
spoken about
Raki, volume, I think you can raise the
PCOS
volume.
issues
I
they
have
face.
raised it. It is not.
Sonam
coming.
Kapoor. The actress revealed that she dealt with PCOS and issues related to it, including adolescent obesity, starvation, and depression. Sara Ali Khan, when asked about her weight issues in Coffee with Karan, she revealed that she suffered from PCOS during her college days, weighing 96 kgs. Shruti Hassan said, at 26, I was diagnosed with severe PCOS. I couldn't control the symptoms no matter how hard I tried. It wasn't comfortable. It wasn't pretty. Victoria Beckham. She has always been vocal about the effects of PCOS on her fertility and how she defeated it with a healthy lifestyle. Daisy Ridley. She took to Instagram to share about her journey with acne treatment that has been a symptom of PCOS. Emma Thompson, Oscar-winning actress, not just spoke about PCOS, but also revealed how she coped with clinical depression in several interviews. Harnam Kaur. She's well known as the youngest female with a full beard. Model, activist, and Guinness Book record holder, Harnam Kaur rocks a full beard, which is a result of PCOS. PCOS.
And it is not easy for all of us to see any patient and with the PCOS going through all the hell of it. It is not only the common people, it is the Bollywood, the Hollywood, everywhere it is there. But some people are vocal about it, some people are not. So it is very sensitive issue which has to be tackled. And here in the literature, there was a beard lady which appeared so many times on the circus shows. And in 1800 century, And today, excess body facial hair is associated with polycystic ovaries. We know that very well. And to evaluate this hirsutism, we know that there is a modified fragment Galway score, which according to which all the different parts of the body, the chart is there, it has to be examined, and the score has to be calculated. Any score for these modified fragment Galway score, total or score of 0 to 36 is there. Any score up to 15 can be labeled as mild hirsutism. A score between 16 to 25 is moderate. Any score above 25 is called as severe hirsutism. For these patients of ours, do remember to evaluate and ask drug history for these patients. Are they on any of the drugs or not? These patients of our Indian origin are very clever enough. They would tell us that no drugs they are taking. But if you ask them, are you taking any Ayurvedic preparations or so? Then later on they tell, yes, I was on all these preparations. And do remember to take that history also, because they are harsh chemicals. At times they do cause hirsutism also. And clinically do look for the other biochemical signs for the virilization for these patients. And hyperandrogenism with slow onset with regular periods, if it is there, then it could be the idiopathic hyperandrogenemia with around 6 to 16%. And in these patients, do remember to get testosterone, see for the ovaries if they are normal or not, and do remember to check for the adrenals and if the history is very fast growing or not. And hyperandrogenism with virilization and the slow onset, if it is there, then we know that PCOS it is, and to the tune of 72 to 80% of these patients. And clinical biochemical markers with PCOM are seen. And according to the Rotterdam's criteria, we need to label them up as PCO patients. Then if the hyperandrogenism with virilization and the rapid onset is there of hirsutism, then we know that we are looking at androgen secreting tumors, which is around 0 to 2% of the patients. And ovarian tumor, if it is more than total testosterone is more than 200, and adrenal tumors, if it is elevated DHEAs of to the tune of more than or equal to 700 micrograms. And imaging has to be done to evaluate and see for the adrenals. Non-hyperandrogenic and the virilization of these patients, we know that it could be hirsutism, which could be the idiopathic origin. Regular periods can be seen in these, normal testosterone, normal ovaries, and non-classical adrenal hyperplasia still has to be ruled out in these patients. When we talk about the management per se, lifestyle modification being the cornerstone and the treatment for all these patients. The first is the lifestyle, and along with the lifestyle management, do ask these patients if they are obese and the obesity is more, and if the age is more, and the BMI for these patients of ours should be taken as a cutoff of 23 and not 25. Do put the patients, if required, on 20 microgram of ethinyl estradiol based oral contraceptive, and minimum duration for the treatment should be around 6 months. And other direct hair removal methods can be used for these patients, but anyways, all these patients would be coming with all the hair removal methods, and then we are the last ones to receive for these patients. And the other second line of treatment would be anti-androgen therapies. The OC pills with the anti-androgens would be doing wonders for these patients. And do remember to give them at least for 6 months to have the results in our hand. And combination of anti-androgens along with the OCPs combined would work wonders for these patients of ours. A word about OCPs, it improves the menstrual irregularities, improves the hyperandrogenemia. Low dose estrogen with progesterone with anti-androgens are better for these patients, like drospirenone, Dynogest, or Norgestimate, which would do wonders. But if the patient is adolescent and less than 16 years of age, with no features of hyperandrogenemia or the features of hyperandrogenemia, are there, then the withdrawal bleeding of at least once in 60 days should be aimed at, and a simple natural progesterones can be prescribed for these patients. The another wonder drug is metformin, which we've been using for our patients, and non-obese PCOS with insulin resistance is also seen in these thin, lean patients. So there also metformin and the exercise is required. And the maximum dosage for the metformin, what we can give is 2000 grams per day. But at times, these patients have lot of GI symptoms. And for those symptoms, they have to start slow onset, and then slowly the dosage has to be increased. And OC pills, when we talk about high progesterone relative androgenicity for these drugs, would be the best would be norethindrone and the levonorgestrel are best for these patients. The other ones would be drospirenone and cyproterone acetates. And if the patient are not responding to these drugs, the other anti-androgens can be added, like spironolactone, finasteride, or flutramide can be added for these patients. And we know drospirenone, or the progesterone which is derived from 17-alpha spironolactone, which would be much better for these. And a pill containing progesterone with low androgenic activity is a better choice in the treatment of PCOS, because the estrogen component of the pill increases the level of sex hormone binding globulin that leads to reduction of the available free testosterone, which can be blunted by the intrinsic androgenic property of the progesterone component of these pills. And the anti-androgens for the adolescent is to be given start if it is very much required. Hirsutism is full blown, but still OC pills we cannot give. Do remember to start spironolactone to the dosage of 25 milligram and slowly increase it as per the requirement. The cyproterone acetate can be added after 16 years of age, and flutramide or the finasteride can be added, and which normalizes the menstrual cycle and the endocrine system of these patients. As it is, the management of PCOS is a multidisciplinary approach, and any patient would definitely require a practitioner, the endocrinologist, at times the gynecologist, the fertility specialist, the dermatologist plays a major role. Mental health, the psychologist and the psychiatrist is required for some of the patients having much amount of virulent symptoms, and the allied health with the dietitian and the exercise is important. Whenever this PCO patient is there, our goals for the treatment would be the short-term issues like improving the body image issues, the self-esteem, listening for the acne and the hirsutism, managing the weight and regulating the cycles. But the long-term issues have to be counseled for these patients. If they are not taking the treatment correctly, they would land up with diabetes, the cardiovascular disease risk, the endometrial hyperplasia, and the future infertility problems which could rise for these patients. And for the evaluation, a detailed clinical history is important for these patients. And do remember to get the LH-FSH level. And we fondly remember very well that the FSH to LH ratio is 1:2 for these PCO patients. Then we know that it is hyperandrogenemia, what we are looking at. As it is during my endocrine committee chairperson tenure, we've come up with these two beautiful posters with the algorithmic approach for the hirsutism and the acne, which are uploaded on the Foxy website. We just have to do is just go on the Foxy volume endocrinology to have the access for all these newsletters, and the Foxy endocrinology and hirsutism you type, and then you get these posters of hypothyroidism in pregnancy, hirsutism, acne. Just the keywords have to be put in. We get all that. And I'm blessed to have these few publications and looking forward to working more with Foxy. These are the references from where the stock is made. And at the outset of the folded hands, I request all of you, I'm standing for Vice Presidency of Foxy. and the voting lines are going to start from tomorrow morning at 10 o'clock. This link is very specific for every candidate, and you will be getting the link by SMS. And just click on the link. You have to just get your OTP by the SMS or by your registered email ID and start voting. And do remember, Singh is king and Rakhi Singh. It would appear as Singh Rakhi on my name. Thank you.
So,
Thank you, Dr.
thank you.
Rakhi, madam.
Thank you,
Yeah.
ma'am,
Thank you.
for such a elaborative and extensive talk on PCOS. Now we'll move on to second session. That is a panel discussion.
Any comments to be made by the chairpersons?
Please, I just want to thank you, Dr. Rakhi, madam, for the comprehensive and enlightening presentation for the PCOS. And it highlights the nuisance of the most complex condition with a remarkable clarity. And it also is a valuable learning experience for us. And also, we have to be very cautious, as ma'am already told us, in labeling the patient as a PCOS, especially the adolescent as well as the adult.
Yes.
So,
Thank you.
Thank
So,
you. Thank you.
Thank you, madam. One small comment from my side, madam,
Yes, sir.
as an endocrinologist.
Yes, sir.
As really pointed out by a lot of our senior madams and about the obesity and especially about the metabolic syndrome, I would like to highlight here, in especially the adolescent girls, which predisposes them to insulin resistance and which becomes the main base or the ground or the soil for all these metabolic and hormonal disorders. So as rightly pointed out by some of our panelists, that from the beginning school time, we should try to inculcate healthy diet, regular physical activity in our children, especially the girls who may suffer from these metabolic and hormonal disorders. Thank you.
Yes, definitely, Dr. Abhyunde. Basically, it is a central obesity which is troublesome for all these PCO patients. And that central obesity is very difficult to go. The other peripheral obesity is easy to reduce. And because of the G6P1, semaglutide is the one which is sensitive to it. And that is a wonder drug, boom, which has come up for these patients. But we need to ask these patients not to do binge eating, do refrain from all those activities and do the exercise and walking continuously. That would reduce. And I fondly tell all my patients, you have your mobile, do walk the talk. As soon as you get a call, unknowingly you will start counting your steps on it. And once you have that lifestyle modification built in you, as soon as it rings, you will involuntarily get up. It takes first 1 week or 10 days to absorb that in your system. Thereafter, you are okay with it.
Thank you.
So, Dr. Rakhi, an excellent talk. And I think since you've been the chairperson of endocrinology, your PCOS, you more or less are the authority for it. The only one thing I would like to add, we have been talking about the management, and we say 6 months is the minimum that we need to give it. So during this particular time, it will be quite advisable for the patients to go in for laser or some other method of reduction of the hair. Because after 6 months, we will need to continue it because you stop it and it tends to come back. So how long would you recommend them to continue with the COCs, and so that they can be off after some time? What other methods can be used only for hirsutism?
Sir, and the other physical corrections can be done simultaneously, but level, the root cause of it would take dedication and continuously doing it. And the hormonal imbalance has to be corrected. So, and the hormonal imbalance to be corrected would take an energy from these patients, a dedication from these patients, that you have to lose weight. And little amount of weight loss would do wonders for them. And like 3 to 5 kg of weight loss, the patient would definitely respond to lasers. The patient would definitely respond to all the other treatment modalities also. And once those laser hairs, the small fragile hairs, they become very thick and porous, to remove them, it will also take that much more time. So that means she's been having hyperandrogenism for a very long standing. That is why those hairs have become very coarse. So that much amount of dedication, if she's doing controlled diet and everything, the exercise, lifestyle modification, she may not require the OC pills for lifelong also.
Okay.
Dr.
What about
Rakhi,
the
that
hair
was an
cream?
excellent
The
talk.
rest of the questions we'll be having in the panel. So,
Dr. Deepika, you want to add something? Dr. Deepika Verma?
yeah, Dr. Deepika.
Thank you, madam, to giving me this opportunity. And Dr. Rakhi, madam, explained everything very nicely. And I think almost all things she covered. And thank you, madam. Nice presentation.
Thank you, Dr. Deepika.
Amit, please see, Dr. Rashmi is also not able to open her video. Please check it up.
Dr. Bindu wanted to say something, I think.
I just wanted her views on lean PCOS. I mean, we were talking about obesity.
We will be discussing this. We have the question in the panel, so we will come to that there. Let's not, let's continue with the panel. And excellent talk as usual, Dr. Rakhi. And I'm sure you will win. We are all with you, and very best to you. Dr. Deepa also, Dr. Shashi Bala also, all four contestants.
Thank you. Thank you.
Megha,
Thank
we
you.
will move on to the second session.
Yes, ma'am. Thank you, ma'am. Now we'll move on to the second session, that is panel discussion. Ma'am, are my slides visible?
Yes, yes.
Yes, your slide will be
Okay,
visible.
ma'am. So I'd like to introduce panelist, Dr. Kiran Agarwal, ma'am. Kiran Agarwal, ma'am, is a director, professor, and unit head at Lady Harding Medical College, New Delhi. She has been a chairperson of Rural Health Committee, Indian Menopause Society, chairperson QI Committee, AOGD, past president of Indian Menopause Delhi chapter, and she has awarded many gold medals, and she has been a thesis guide, has publications in international and national journals. She has a special interest in adolescent health, PCOS, and menopause. Welcome, ma'am. Dr. Rashmi Mishra. Ma'am is a director, Oregon Fertility and IVF, New Delhi. Dr. Dolly Mehra, ma'am is senior obstetrical and gynecologist at Mehra Nursing Home, Ratlam. Dr. Bindu Bajaj, ma'am is a professor and head of department of Obs and Gynae at VMMC and Safdarjung Hospital. She has a special interest in reproductive medicine and laparoscopy. Dr. Aditi Rathod, ma'am is a consultant at Rathod Nursing, Jeora, and she's executive member of Safe Motherhood Committee, Proxy. Dr. Jashweta Kaul, ma'am. Ma'am is a director at Nirvik Care Center, Women at Indore. Now our moderator for this panel, Dr. Piki Saxena, ma'am. Ma'am is a director, professor, and unit head at Department of Obs and Gynae, and she is also in charge of ART services at Lady Harding Medical College. She has a special interest in IVF and reproductive medicine. Dr. Neeti Tiwari, ma'am, is a senior consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital. Welcome, ma'am.
Thank you, Megha. Can we start with the panel now?
Yes, ma'am.
Yeah. You can stop sharing so that Dr. Piki can start sharing. Dr. Piki?
Yeah, Amit, please make me the, let me share the, yeah. Is my slide visible?
Yes,
Dr.
Yes, yes, ma'am.
We can see it, yeah.
Okay, okay. So, PCOS, I think it's a syndrome we all know, and it is a multi-system endocrinopathy involving the hypothalamus, the pituitary, the ovary, the pancreas, liver, fat tissue, and skin. So all the organs are included in this, and there is a vicious cycle Basically, the problem is probably the insulin resistance, and there are some genetic factors. We know some genes are attached to it, and it passes from family to family, from one generation to the next. And throughout the life approach, from starting from intrauterine life, as we were discussing earlier, it starts in women who are having hyperandrogenism, women who are having GTM, women who are having high BP or obesity. During intrauterine period, their female children, they have epigenetic changes so that these things are transmitted as childhood obesity during adolescent period, during childhood, and as they grow up, they develop number of problems. In adolescents, we see that these girls are coming with irregular cycles, they have early breast development, they have so many cosmetic concerns like acne, hirsutism, hair loss, acanthosis. So they have a very low self-esteem. They are psychologically very disturbed. Once they get married, they develop infertility. And after taking treatment with infertility, when they conceive, there are more chances of having early pregnancy loss. During pregnancy, because they are already pre-diabetic, they develop preeclampsia, they develop GDM, and all the associated complications. And the problem does not end in the perimenopause and even in the menopause. Dr. Kiran is doing an excellent work in doing the metabolic, studying the metabolic problems in perimenopause and menopause. And I'm sure every one of us will agree that this problem is not ending in the reproductive period. These women, even after menopause, they are having metabolic syndrome, full-blown metabolic, full-blown type 2 diabetes, coronary artery disease. Sometimes they develop CA endometrium and lot of other complications. And the underlying pathology is insulin resistance and obesity. Most of them, nearly 80 to 85% are obese. But then we also have a phenotype where we have lean PCOS, and we are going to talk about it. So we will be starting with the first case scenario. This is a 16-year-old girl. As you can see, she's obese. Her BMI is 30 kilogram per meter square. She had her menarche at 13 years and she has very irregular cycles. She bleeds for 5 to 6 days and the periods are delayed for 2 to nearly 2.5 months, 60 to 80 days. She has coarse, dark, androgenic hair growth on the face and lower abdomen, not the soft villous ones. So we need to differentiate between the hyperandrogenic hair, these hair for the PGs who are attending. These hair are thick, just like your pubic hair and axillary hair, whereas the villous hair are the soft hair that the newborns are having, and they are not androgenic. So this is the difference between the two. And she's also having progressively worsening acne on her face and back. She has a lot of, nodular lesions and scarring also. And family history says that the mother is also having type 2 diabetes. So a very important question comes to our mind because these changes are overlapping with the physiological pubertal changes. So how will you distinguish whether she has PCOS? We need to be very careful. We cannot label the person as having PCOS starting in adolescent. How do you distinguish adolescent PCOS as vis-a-vis puberty changes? So any of the panelists can take this question. Dr. Kiran ma'am, will you like to take this question?
I know it is very important, because the three important component of PCOS, that is, we have irregular cycles suggesting of anovulation. We have clinical or biochemical evidence of hyperandrogenism. And third is polycystic ovarian morphology. So when you're addressing an adolescent, the post-menarche irregular cycles will be a part of normal physiological process of maturity of the HPO axis. So till 1 year, if the child has irregular cycles, we should not be bothered. For the next 3 years, it has been defined by all societies that if the cycle is
less than 21 days or more than 45 days, then only we label it as abnormal, or one cycle persists for more than 90 days. And beyond that, the cycles fit in as per the adult regime, that is less than 21 and more than 35 days. So that would be irregular cycles. And hyperandrogenism, as documented by hirsutism, significant. It is not the vellus hair, as you rightly said. We are looking at the coarse hairs. And the third thing is we are looking at acne. So acne is also a very routine feature of adolescence. So mild acne, which are not nodular, which are not causing scarring, which are not like getting treated by the treatment, would be significant. So nodular ones, which are causing scarring, which are present on chest and abnormal areas, which are not going away by treatment, would be a feature of hyperandrogenism. So these are the two things which are needed to diagnose an adolescent PCOS. Otherwise, we do not need to look at the ovaries because cystic ovaries may be present in an adolescent. So we are looking at a gynecological maturity, which will occur by 8 years post-menarche, where we should be looking at the ovaries. But definitely, if there is any, I would like to mention it here that just don't ignore the ultrasound. If there is any cyst, there can be a malignancy, there can be a benign adnexal mass. So if by chance some ultrasound has been there, which is showing some significant tumor of the ovary, that should be looked into, but not for polycystic ovarian morphology. And otherwise, definitely like this patient, we have already presented a 16-year-old girl with type 2 diabetes mellitus in the mother and having acne, and she has hirsutism, she is obese. So definitely would fit into a diagnosis of polycystic ovarian syndrome. And if one of the two features are present, like either the hirsutism or irregular cycles, then we'll say that that child is an adolescent at risk and should also be looked into carefully and followed and treated if needed in discussion with the parents.
Absolutely. Any other panelists wants to add any point?
I just want to add something. If there is acanthosis nigricans, that also indicates hyperandrogenemia. So we should look into this aspect also, because the picture which was shown definitely shows that she has a raised BMI. So acanthosis nigricans, if it is associated, will tell us about the hyperandrogenemia and the metabolic syndrome associated with it.
Also,
Very important points. We must look at the back of the nape of the neck and all the pressure points, just not the neck, because that means that the girl is having severe insulin resistance. And then we have to see for the clinical signs of hyperandrogenism. And if they are not present and we have a strong suspicion, then we should go for biochemical testing. Yes, Dr. Bindu, you were making some
I
point.
was wanting to say that apart from whatever Dr. Kiran has said, and it has been another addition has been done, even the number of acne are important. How much is it is considered that less than 10 acne which are non-inflammatory. Of course, Dr. Kiran said that it is a lot of comedons, thick nodular skin.
Nodularity.
So without any inflammation, if there are less than 10 acne, they can be taken as pubertal changes only.
I will be just showing the objective criteria of marking acne and all those things. So we will just come to it. Dr. Rashmi, would you like to do an AMH for an adolescent PCOS or for an adult PCOS for making the diagnosis? I'm not talking about the prognosis of fertility.
No. So normally AMH is not reserved for diagnosis, but AMH to differentiate whether her delayed cycles are actually because of PCOD or is it because of poor ovarian reserve. Because sometimes we do see very, very young patients with very, very low AMH. So that way it might add to our diagnostic too, but not for the diagnosis of PCOD, no.
Yes. So I think it is extremely important that we understand that the irregular cycles are defined as they are found to be normal in the first year. You will not do anything if they are irregular in the first year. But after first year and before third year, 3 years, if she is having periods before 21 days or longer than 45 days, or after 3 years post-menarche, if she is having periods less than 21 days or more than 35 days, or she is having only less than 8 cycles per year, or after 1 year of menarche, if she is having bleeding anytime more than 3 months, okay, later, that is more than 90 days in any cycle, then we say that this is irregular cycles even in post-menarche. And a very important point is that we need to remember primary amenorrhea by the age of 15 or more than 3 years post thelarchy is also taken as irregular cycles, but we need to follow these girls prospectively, and reassessment is advised at or before full reproductive maturity, at least 8 years post menarche. So we should not be too quick to label a girl as PCOS because it has severe, mental and psychological repercussions, and we don't need to treat all adolescents with irregular cycles. On the other hand, as told by our panelists, there is no need to delay the thing. All high-risk girls should be followed up so that we don't miss out the diagnosis of PCOS, because it is definitely going to be associated with metabolic complications. Ultrasound is not recommended because anyway these girls may be having multicystic ovaries, which is natural. And the other thing is that the ultrasound is recommended to be done transvaginally. And in adolescents, we cannot, this is not feasible. And also these girls are obese. So a trans-abdominal ultrasound is not going to have a very good sensitivity. That is why these girls, PCOM morphology may be there, trans-abdominal scan may not show those polycystic ovaries, and transvaginal is not feasible. That is why ultrasound is not recommended for diagnosis of adolescent PCOS. So coming to the next question, how will you work up a woman who is having PCOS? And what are the most reliable clinical markers for hyperandrogenism? It has already been discussed. So Dr. Dolly, would you like to discuss this point?
The most important clinical marker for hyperandrogenism in this age group will be the total testosterone level or the free androgen index, which was explained by Dr. Rakhi very well, how to calculate the free
We
androgen
are talking,
index.
Dolly, we are talking about clinical markers. We will just come to biochemical. The ones you were talking about, acanthosis and all those.
Yeah, so basically, it is again the features of hyperandrogenism, irregular cycles, acne, if the number of acne is more, the type of acne, and the acanthosis nigricans, along with central obesity, if it is there, if the BMI is raised. These are basically the clinical markers for PCOS in adolescent girls. And
Hair
then
fall also probably.
Hirsutism is the only, I mean, it's the most dependable. I mean, hirsutism should be
most important.
Most important.
Most commonly seen. And also acne is another very, very important thing, as has already been told. So would any of the panelists or like to tell us how to define obesity in Asian Indians? Because the criteria for the Caucasians and for Indians is different. So would anybody like to answer?
BMI of more than 23 will define as obesity nation, while for the Western population, it is more than 25.
Caucasians.
Yeah,
absolutely. So let us see, when we are evaluating a woman with PCOS, we have to take a detailed clinical assessment. Menstrual history, family history is another very important thing. Obesity, PCOS, hypothyroidism, or diabetes. And then we need to look for hirsutism, acne, alopecia is also very important. These are the clinical markers, acanthosis, and in very severe hair and syndrome type of things, there could be clitoromegaly and voice change. This is mostly seen in virilism. And if at all it's a clinical diagnosis, so we don't need to do any test if we want to make the diagnosis of PCOS, and we can immediately start with MNT, or if it is very severe, we need to do, however, these tests. The BMI needs to be measured. Waist-hip ratio is very important because the Indians have a thin fat phenotype. So their waist is more, their visceral obesity is more, which is more closely linked to cardiovascular outcomes. So it is very important, and it does not need any specific instruments or something. So BMI and waist hip ratio should be done for all. Blood pressure, lipid profile, and 75-gram OGTT. These are also recommended in the latest international guidelines of PCOS
2023, and it is now recognized that PCOS is a pre-diabetic condition, and it is a very high risk precursor for developing GTM. And as also pointed out by some of the panelists, we need to assess their psychological well-being also, the stress, anxiety, whether they are able to sleep. There may be sleep apnea because of obesity. So quality of life, eating disorder, all these things need to be looked. Acne, hirsutism, these things. So for the benefit of the postgraduates and the junior colleagues, the modified Ferriman Galway is this type of thing in which we are marking the number of hair. All these 9 areas are taken and you mark from 0 to 4, and when you calculate, you add up all, and if the score is more than 4 to 6, it is known as modified Galway score, and you label the girl or the woman as having hirsutism. And the original FG Ferriman Galway score, there were 11 sites. In the modified ones, the arms and the legs have been removed. So this is one of the things. The Ludwig criteria is very rarely mentioned. So we should also look for this type of, baldness. So this is category 1. Then this mang is becoming more broader. And here you can see there is diffuse thinning and see-through alopecia of the top of skull. This is the grading, the objective grading. It is good to take a picture of the adolescent or the girl when she's coming for the first time. Also, we should ask them if they have recently had any androgenic treatment or any waxing or laser treatment, so that then we will not come to know the actual thing. And this is the grading. This is the Kuppa grading given by the Indian dermatologist, mild, moderate, severe, on the basis of number of comedones, papules, and scarring. So, and nodules, cysts. So this is the thing we need to know. And Prader scale, I'm not going to talk much about. This is for clitoromegaly, which is rarely seen. The obesity, we can just see mota mota dekh ke, we can see if she's pear-shaped or she's apple-shaped or she's avocado. The best one is this one, pear-shaped, where the hips are more. We can see that the waist-hip ratio is less than 0.8. 0.81 to 85 avocado, the waist is becoming broader. Here the waist is more, and this is the worst one, the apple one. And for the Indians, you can see this Asian classification. 22.9 say come is normal, overweight is more than equal to 23, 27.5 and more is obesity, and then comes severe obesity and morbid obesity. If the girl has got more than 3 of these symptoms, we say that she has metabolic syndrome. So central obesity, BP, triglycerides, HDL, we see the lipid profile also, and fasting blood glucose. All these things are taken into account. So Dr. Abhyuday, we would like to know from you, is Dr. Abhyuday there? So I think Dr. Abhyuday is not, the connection is not okay. So
Yes,
any
madam, yes,
panelists? Yeah, yes.
That
So
is
sir,
there.
yes,
we would
sorry,
have
sir.
your
Yes,
opinion
ma'am.
on the metabolic syndrome and the metabolic complications of PCOS.
Yes, thank you, madam. And I think really a very important uh, discussion about the metabolic syndrome. And as very well highlighted, definitely this makes our adolescent girls or even girls with PCOS who are having maybe a normal BMI, as we were talking about BMI, but we have seen, even we have published a paper also with the higher insulin resistance seen in even lean PCOS females also. And the basic pathophysiology behind this is again, which we have discussed in the earlier slides, the abdominal obesity, especially the visceral adiposity. That's why it was highlighted that along with BMI, which may not be a very good indicator of overweight or obesity, we should get a waist circumference and maybe a waist hip circumference also if available. So here we can see in our metabolic syndrome evaluation. Any 3 out of these things, the abdominal obesity, the high blood pressure, maybe a fasting blood sugar levels which are in pre-diabetes range, maybe like just above 100 and less than 126, and definitely, as most of we Indians with insulin resistance have a low HDL level and a higher triglyceride level. So any 3 of these should alert us that these patients are not just suffering from the menstrual irregularities or the hirsutism, but we should start counseling them about the lifestyle changes also, and which may
Absolutely.
lead to this. Thank you.
Thank you, Dr. Abhyuday. Very nicely said, and we will come back to you again. So what are the tests we are doing in clinical practice to, if she is not having any hirsutism and we feel that she is having PCOS, what are the tests you order in your clinical practice to determine biochemical hyperandrogenism? Dr. Rashmi?
Total testosterone. This is what I usually order.
Yeah.
Even free
Anybody
androgen
else
index
wants?
can also.
Yes. So free androgen index, how do you measure?
So that is total testosterone and SHBG.
Divided by SHBG.
Divided by SHBG into 100.
So that is a very good method, because SHBG is very important, because if the SHBG level is low, then the binding of the testosterone is low, and the free testosterone is the one which is the culprit for causing all the hyperandrogenic signs and symptoms. So generally total and free testosterone need to be measured. And if these are not elevated and she's having hirsutism, then only we go for androstenedione and DHEAS. And this DHEAS is coming specifically and only from adrenals. That we need to remember. And if there is a problem with the adrenals, only then DHEAS will be raised. And the international guidelines also say that the method used for testing testosterone should be LCMS method. So this is very important for all of us to know. So what are the, we know that there are 4 phenotypes of PCOS. So which are the ones who are metabolically worse? And why should we do this classification at all? So anybody, any of the panelists can take this question.
So out of all the 4 phenotypes, I guess the type A and type B, which are associated with hyperandrogenism, they are the worst. They are mostly associated with the metabolic syndrome. So these are the type of patients जिनमें कि हमें सबसे ज़्यादा metabolic syndrome के लिए देखना पड़ेगा.
Bilkul, absolutely. So we know the culprit is hyperandrogenism, and whichever phenotype is having H, this the A1, which Dr. Rashmi just talked about, you know, these 4 phenotypes are combinations and permutations of the 3 clinical signs and symptoms. So the phenotype A, B, and C, these are all having hyperandrogenism. So these are all metabolically worse. So we did this study in Lady Harding where we evaluated the endocrine and metabolic profile of different PCOS, and this is the thing we found. And O plus P phenotype, where there's oligomenorrhea and polycystic ovary, hyperandrogenism is not there. Those were the ones who were not metabolically that bad. Otherwise, these 3 were very bad. And the other thing that everybody is talking about is the lean versus obese. So this was another paper we did in Lady Harding, where we evaluated the clinical, hormonal, and metabolic assessment in relations to BMI. And what we observed was that this is very, very important. Insulin resistance was present even in lean PCOS as compared to the obese. So although obese ke andar there were more strong family history of diabetes, impaired GTT, lipid profiles were worse, but even the lean ones were having anything. How would you like to treat the lean PCOS patients? Dr. Kiran, would you like to come in?
Yes, the lean PCOS,
Please ask them to enable my video. I think I've gone to another link.
Amit, please enable madam's video, please. सबका वीडियो आप enable कर दीजिए, please.
So the lean PCOS.
Just a second.
Yeah.
Done.
Ma'am, आप बोलते रहो, we can hear you.
Yeah. Okay. So the
Now we
lean
can see.
PCOS, is where if you look into the history, you need to ask them about their family history of diabetes. Very, very important. And you also look at, though apparently the BMI may be all right, you need to look at their visceral adiposity. So the waist to height ratio needs to be seen in all these children. And surprisingly, you will find that there is a higher incidence of family history of diabetes in these children. And also the waist is heavier as compared to the BMI correlation. So once we look, and also whenever we are talking about hirsutism, we also need to take a very careful history, like how quickly it has developed, how rapidly it has, what was the severity, is it a slow onset one? And then obviously the lifestyle. So once we've evaluated all this that we've been discussing, and we also check for their insulin resistance, a 75 grams OGTT, and then we decide about the management, because they should still be asked for a lifestyle management and exercise. 60 minutes of good exercise every day would still help them, even if they are lean, and that would improve their metabolism. We should not think that they are lean, so we do not need to advise them lifestyle management. Junk food still should be off for them. And if we find that metabolically they're all right, but there is an insulin resistance, probably we can go on to the metformin arm for them. And if hirsutism is the main problem, then maybe we start with a COC with the low dose estrogens for them, combined with the lifestyle management. So they also should be counseled, and they should also be counseled about their long-term problems in a background of all the three components of PCOS.
I think very well answered by ma'am, because this question was there in the chat box also. And all our PG students also keep on asking this question. So it is very important to counsel the lean PCOS also, that the same diet, exercise, everything, and metformin or inositols, whatever we are giving to obese PCOS, the same should be given, because probably their visceral obesity, their waist hip ratio is more. They are also having hyperandrogenism, and sometimes they are having worse hyperandrogenism, and that acanthosis, insulin resistance, all those are also there. So there's no need to restrict too much of calories, but physical exercise and all the other therapeutic modalities are the same. So now coming to anybody else wants to add anything to this, or any of the panelists?
I think reduction of stress is important, stress reduction method to
very
reduce
important
stress in thin
very,
patients,
very,
especially when they are having stress issues.
Obese, thin, any PCOS patient, I think stress is very important, because that is going to increase our cortisol, which is going to cause dysglycemia, more of dyslipidemia, and again the vicious cycle of obesity, hyperandrogenism, all those things will come back. So please tell us what are the main modalities, how you will start with the initial management for the adolescents with PCOS?
Yeah. So basically, Dr. Picky, it all depends on to which symptom the patient has presented, because so many times they just get an ultrasound done and they come running away with they come with the diagnosis, I've got PCOD. So the important thing is that we have to treat according to the symptom. Whether they actually need any treatment or not, that is also very important. So maybe sometimes just lifestyle.
Yes, so this is what is the most important thing. And the first line thing is lifestyle. Mota obese hai, patla obese hai, any PCOS patients, once we make the diagnosis, lifestyle is the most important, which Dr. Rashmi has pointed out. And even a little weight loss of 5% is going to improve the insulin sensitivity, and the glucose will be utilized more by the muscles. The glucose level will come down, insulin resistance will improve, and the clinical, metabolic, and hormonal profile will also improve.
So the lifestyle changes have to be, they should be in a habit, and there should be a major caloric restriction basically in these patients.
there should be this is what is mentioned, which is a very nice point I found in the international guidelines. There should be a goal setting, and बहुत बड़ा goal नहीं, it should be small baby steps, so that they feel motivated when they are able to go from one stage to another. Self monitoring, problem solving, assertiveness training, reinforcing the changes again and again. Every time she comes back to us, एक बार बता के काफी नहीं है. We need to tell them each time कि खाने में क्या खाना है, what are the things they need to restrict, how much exercise they need to do, prevent relapse, and optimize weight management, healthy lifestyle, and emotional well-being, as also pointed out by all the esteemed panelists. And they should have SMART goals: specific, measurable, achievable, realistic, and timely. बहुत बड़े goals बनाने से they get demotivated. And as Dr. Bindu said, 1 hour of moderate to vigorous exercise should be done every day, which will improve the muscle and bone, and the resistance exercises, walking, gym, Zumba, swimming, anything, whatever is possible in their socioeconomic, this thing should be encouraged. So coming to the management of hirsutism, the temporary methods could be there, permanent methods like electrolysis, thermolysis, the laser therapy could be there, topical could be eflornithine, minoxidil is very good, you can apply on the scalp for androgenic alopecia, and retinoids for acne. So what are the pharmacological treatment options for managing hyperandrogenism? Anybody would like to take this question?
So OCPs themselves are useful for reducing the hyperandrogenism, but in case they are not effective, then one can switch from OCPs having cyproterone acetate, although they are more they have chances of venous thromboembolism with them. And secondly, one can add drugs like spironolactone, finasteride, and among them, spironolactone is perhaps the most used drug. And finasteride also can be used. The dosages of spironolactone, as already shown, is around 100 to 120, and gradually increasing it to up to 200 milligram per day. But of course, endocrinologist reference and dermatologist, they go hand in hand whenever we are taking such steps.
Yes, madam, definitely.
So it's very important to involve Dr. Abhyuday also, because it has to be a multi-team disciplinary action. So you can come in, Dr. Abhyuday.
Yes, madam. Just one more comment. It is be seen that even metformin helps a lot when we get a lot of patients who are resistant to only OCPs. Some people may not tolerate these spironolactone. So adding a small dose of metformin also, which again reduces the insulin resistance, may also help in few of these patients.
So the first line obviously is lifestyle modification. Second, because most of them, as Dr. Rashmi very rightly said, jo symptoms leke aa raha hai, we need to treat that first. So menstrual irregularity is the most common. So we start with OCPs. As I said earlier, the estrogen is going to increase the SHBG. So when the SHBG will increase, it will bind the testosterone. Free testosterone will come down. Hyperandrogenism will improve. And the progesterone is going to, give a negative feedback to LH. And in that way, the cycles will be regulated, endometrial hyperplasia will be less, and they also are going to, we can also add metformin, as Dr. Abhyuday said, because it is going to improve the insulin sensitivity for these patients. For hyperandrogenemia, as correctly said by all the panelists, combined oral contraceptive pills, it could be cyproterone containing crimson 35, drosperinone containing, free days, Dynogest is another anti-androgen, and desogestrel novelone. So these need to be given for 3 to 6 months. It's a good idea to take the photograph of the bacha or the patient when she's coming and tell her that the cycle of the hair is nearly 3 months. So don't expect any miracles. It will take at least 6 months. And when she's coming next time, she should not get her waxing or hair removal done. We should be able to see how much change is there from the initial one and the later one. And the vellus hair will not go. But Yeah. Yes, Dr. Deepa.
Already 5:30. Can we move into the next
Yeah,
talk?
yeah. We move.
Or
And the anti-obesity drugs are liraglutide and semaglutide, which are coming into this thing. So I will skip this because we are running short of this thing. Metformin is very important. It can be started for adolescents or any PCOS patients. It's an insulin sensitizer. We start in the increments of 500 milligrams, BD, TDS, and maximum doses 2 grams per day. And it should be started if we have any clinical or biochemical this thing of insulin, evidence of insulin resistance, impaired glucose tolerance, impaired fasting, or diabetes, or HbA1c more than 5.7, or hyperandrogenism, or HOMA IR more than 4.5. So the other options are N-acetylcysteine, inositols, and these are the things which are in the gamut. And Dr. Abhyuday can add later on probably how semaglutide, which is now coming up for anti-obesity drug, the Ozempic and Wegovy. So we can add that later. I will not go to this. And we come to PCOS and infertility, and I hand over to Dr. Neeti, and I'm so sorry for crossing over the time. I did not have the watch in front of me. Dr. Neeti, please continue. Should I stop sharing and you can share your slides? Or should I keep on moving?
Sure,
I'll
I will
stop.
share. Yeah.
Please share.
Just
Dr. Abhyuday, you can just in one or two quick sentences, you can tell us about semaglutide till the time Dr. Neeti,
Yes.
shares
So
his.
thank you, madam. Very lucid and a very comprehensive presentation. I think it covers most of the important aspects in the management. Yes, GLP-1 receptor analogs like maybe semaglutide, or earlier we have liraglutide, and now we have tirzepatide also, which is a combination of GLP-1 and a GIP. They have shown to be having lot of pleiotropic benefits other than just taking care of the patient's blood sugar levels, and now they are being recommended for treatment of obesity or overweight patients with problems like maybe a cardiac problem or maybe a problem like PCOS. And lot of data are available now where these drugs are used in PCOS females, especially who are quite overweight or obese with significant insulin resistance, abdominal obesity, and maybe a pre-diabetic state. So these drugs are like maybe now a new era will be open when we start using along with our routine OCPs, anti-androgens, these anti-obesity agents, which not only help the our patients now, but maybe for various metabolic disorders which we have discussed in future will be taken care by them. Thank you.
Thank you.
Thank you so much. So we move on to our next case, and because the time is really short, I will try to wind it up in 10 minutes because we have to have another talk after that. So I'm not able to move the slide. Yeah. So Mrs. X, 28-year-old, and Mr. Y, 30-year-old, married for 4 years, are trying to conceive since 3 years. And Mrs. X has irregular cycles, often takes withdrawal for progesterone. She has coarse dark hair growth on the face and lower abdomen, which has progressively increased over the last 2-3 years with a progressively worsening acne. And she has a family history of her mother being a diabetic. Now her BMI is 32 kg per meter square. She blood pressure is within normal range. Acne, hirsutism, and acanthosis nigricans are present. Her AMH is 6.8 nanogram per ml, and HbA1c is borderline right now. Rest of the reports are normal. Ultrasound is showing a PCO. So, how will you manage her? So, Dr. Shweta Kaul Jha has not been speaking for a while. Dr. Shweta, would you like
Thank
to?
you. Yes, madam, she is a case of PCO. As we can see, all the criteria are being fulfilled.
So first of all, I would like to have a lifestyle management in this case, which has been very nicely already discussed. All the parts that we just want 5% weight loss. Also, if she does, she might have improvement in her cycles. And then if she has regular cycles, she will have ovulatory cycles and she might conceive also because analysis is normal.
Yeah, so we have already discussed the importance of lifestyle
Yes.
intervention in detail. But what
Diet,
is important is
exercise,
that in
drugs.
infertility also, the lifestyle intervention becomes the first part. And as Dr. Picky also emphasized that it is as important in a lean PCOS as, is in the obese PCOS. Of course, the obese have to lose weight and lean have to maintain it, right? So lifestyle intervention, behavioral strategies, goal setting, all this we discussed, and how much exercise they should do. So she was talking about adolescents and adults. When we say that they have to aim for a minimum of 150 to 300 minutes of moderate intensity activities or 75 to 150 minutes of vigorous intensity aerobic activity per week. So it has to be distributed over a week. Now coming to the medicines, what will be your first choice of drug for ovarian stimulation in PCOS and dose? Dr. Kiran, if you can, ma'am, take this question. Dr. Kiran, ma'am?
Yes. Letrozole, out of letrozole and clomiphene citrate, letrozole is the drug of choice, and the results are much, much better. And
And do you
actually,
consider, ma'am, this patient suppose come to your OPD, do you consider doing, when do you consider doing a tubal testing for her?
the tubal testing depends on the individual person, whether we want to do it or not. If we find that there is no other factor, there has been no other problem, all the other parameters are normal, the semen analysis is all right, then at times it may be an individual choice in discussion with it. But I feel that once we go in for, it's my personal opinion, though the evidence says that it may be left to be assessed individually, but I feel that the tubal testing should be done so that once and for all the patient is assured before she goes into medications and follow-ups that the tubes are fine.
So
We
Dr.
can have a panel's opinion about that.
Yeah, it's an interesting question. So Dr. Rashmi, in a treatment naive PCO, we know that she's anovulatory. Would you consider tubal testing before ovulation induction?
No, I will not consider for maybe around 2 cycles. I will not consider because the tubal testing being invasive test and the only test which is very painful, which is slightly painful, I reserve this test for maybe 2 cycles. If she has ovulated well and still she has not conceived, then yes.
And Dr. Bindu, ma'am, what do you do in your setup?
See, ours is a big setup. If the patient is coming 1-to-1, just like in private practice, then you can afford to have not to say have 2 cycles. But since it is normally attended by many residents also, so as a routine, we have made it that you get a tubal testing done and then come to us, so that it doesn't come that 6 months later you come to know that tubes were blocked and we were unnecessarily stimulating her and follicular monitoring her also. So on a yes, 1-to-1 patient, if the patient comes, I can also avoid doing tubal testing immediately because we know she's anovulatory and she needs ovulation to start with.
And Dr. Shweta, when do you consider IUI?
Only for male factor infertility. So if there is mild male factor, then I would like to go for IUI, very frankly. Suppose she's a resistant PCOS in which we are adding gonadotropins.
Yeah.
Okay. Then just to enhance the success further, because we know that letros with gonadotropins, and if we club IUI, then we might get a 20% pregnancy rate because she's spending on gonadotropins. So to add on to success, I might add IUI, but per se, IUI is mainly for male factor.
And when, what do you do if suppose patient, has tried 3-4 cycles of ovulation induction time intercourse and does not conceive? Do you consider IUI, adding the IUI in that patient?
Of course, to increase the success rate,
Chances,
anyways, yes, we'll go for
So
it.
yes. So basically letrozole is a first choice, we know. It's a first choice drug now, and we are all using it over clomiphene citrate. It has come up. And tubal patency, as all our panelists have said, this is what the guidelines also say, that it depends upon the personal history, population prevalence. So considering the fact that maybe, the tuberculosis, genital tuberculosis is common, or what kind of population are you seeing? If you are in a public sector, you are seeing patients coming from a lower socioeconomic strata where tubal pathologies may be more. Tubal patency can be done even before starting ovulation induction. So this lady, she tried 3 cycles of letrozole. First cycle with 2.5 milligram, and then because there was no response, then 5 milligram, and that was given another for 2 cycles, but no ovulation. So basically she just failed to respond to uh, letrozole. So Dr. Dolly, if you could say what will you do next in this patient if she has failed to respond to letrozole?
If she doesn't respond to letrozole for say around 3 cycles or rather 2 cycles, then if the tubal testing has not been done, then I will go in for a diagnostic laparoscopy with ovarian drilling.
Okay.
Or else, you can also go in for gonadotropins in these patients and see if they are ovulating or not. But particularly in lean PCOS and those with high LH, I will go in for ovarian drilling.
Okay. Dr. Rashmi Sharma, what do you do normally in your practice?
So, if the patient has not ovulated in the first letrozole cycle, then in the second letrozole cycle, yes, I would add number one metformin. Number two, I will continue to encourage her for weight loss. And if
Yes.
it's 5 mg also she has not ovulated, and if the infertility duration is not really very big, I will tell her for 2 to 3 months of weight loss, and then maybe come back. Even if she loses around 5% of her weight, then her chances of having success with the oral ovulation induction are much, much better. So it all depends on the patient understanding, and the duration of infertility. So if it's a short duration, I will tell her, see, I don't want to give you injections are costly, injections are risky, and so that would be my approach.
Okay. And do you, anybody or you consider extended letrozole kind of regime or
Yes.
anything?
Yes, in fact, higher dose of letrozole like 7.5 mg.
Yeah.
Also, I have given in many of the patients, especially the obese ones, and sometimes they do respond to 7.5 mg. And sometimes a step up protocol, like first day 2.5, second day 5, third day 7.5, fourth day 10 mg also has been reported in the literature. I have used in one patient and with success in that patient.
Okay. Anyone else has any kind of experience with letrozole different regimes?
I'm not using letrozole in other regimes except for the routine third to seventh day or second to seventh day, sixth day. But I may like to add some kind of a steroid, dexamethasone also, depending on how hyperandrogenic is she. So that also sometimes help in this patient.
And would anybody think of giving clomiphene, or have we completely forgotten clomiphene?
No, a
Especially in
third
public,
cycle with clomiphene may be
especially
okay.
in public sector, would you think of trying clomiphene? Anybody?
So we are giving
Yeah.
clomiphene, ऐसा नहीं है. We are giving clomiphene, but yes, a PCOS labeled patient, we don't give clomiphene routinely.
Okay. Okay. Because we have tried this, that sometimes in letrozole resistant patient we try clomiphene, and sometimes you do find
Yes.
that these patients might, those who have failed to ovulate on letrozole may ovulate on clomiphene. So metformin
Madam,
versus
how about
inositol.
extended letrozole?
Yeah, that is what Dr. Rashmi Sharma was also talking about. So you
No,
can
she
give
said
step up,
step
you
up,
can
I
give
think.
extended. Though I myself also doesn't have a lot of experience in giving extended letrozole regime, but it is given in literature. You can try in your patients, especially those who are not willing to take gonadotropins. So we can try this extended letrozole regime also. But remember, one thing with letrozole is that with clomiphene, we are always worried about endometrium, and we forget that in even letrozole has a detrimental effect sometimes on the endometrium. Sometimes the endometrium goes low in letrozole cycles also. So when you are giving letrozole for a longer time, especially say 10 days or more than that, how good it is going to be on the endometrium, that also we need to see. So now coming to metformin versus inositol, Dr. Rashmi Sharma mentioned, yes, if the patient is not on metformin till now, Though, metformin is usually the first drug we start in an obese patient before ovulation induction. But if she's not on metformin and she is not responding to your treatment, better to start metformin, wait for 1 or 2 months, tell her to lose weight, tell her lifestyle modification. And we have seen wonderful results in our practice, that if with weight loss and starting metformin, next time when she comes and you give letrozole the same dose and she starts responding. So this is very important. And inositol, though people are giving inositol, my experience is also limited. I don't know, what about the panelist, anybody who feels that inositol could be better than metformin in their practice in PCOS patients?
We combine it rather than giving alone. And once in a while, patients who do not tolerate metformin, I may end up only giving inositol. Otherwise, I give both sometimes, and sometimes only metformin, depends on the
But the
sources
kind
of
of
status of.
confidence you have with metformin, na, ma'am?
Yeah, I have
As
lots of
compared to
confidence in
inositol.
metformin.
Yeah, Dr. Kiran Agarwal, ma'am, what do you feel about inositol?
I feel that metformin is definitely better.
Yeah.
Inositol seems to be a thing which is added on, may or may not be effective. We don't have proper trials and we don't have proper results.
And as
So
ma'am said, even I have tried in patients who are not tolerating metformin. Then we think of, if you want to give some
huh,
sensitizer, then
maybe you can add on, but I don't think so. Anyone has very documented results of use of inositol and the outcomes.
yeah, and even the evidence does not support inositol much. So now coming to the other definitive options. So suppose we have decided to give gonadotropins, as Dr. Dolly Mehra was saying. So are there any benefit of type of gonadotropin, HMG versus recombinant? Dr. Rashmi, in these group of patient, do you want to give recombinant, or do you think HMG will also work?
So, one thing is, Dr. Neeti, for the purpose of just IUI or just ovulation induction, in my practice, I hardly ever use gonadotropins. In my personal opinion, I feel if patient has to take so many injections, and with just a little bit with IUI also 15 to 18% of success rate with slight risk of hyperstimulation and multiple pregnancy also, I try to encourage them for IVF. That if we have to use gonadotropins, why not proceed to IVF? But anyways, if I will have to use, sometimes I do, then it will be recombinant FSH.
Okay. Dr. Shweta Kaul,
Yes.
would you like to add something in
Yeah,
this?
yeah. I regularly use HMG for PCOS patients, especially if they are going for IUI. And we can use, basically, we can use low dose step up protocol. But if we are giving like 75 minutes daily for 7 days, then we have to initially only counsel them that she might hyperstimulate also. So are they ready for for a conversion? Otherwise, they should not go for gonadotropins or for a low dose step up protocol. Then the conventional protocol is like 75 minutes, 3 days. That is all we do in Indian scenario, mixing them with the oral gonadotropins, oral letrozole. So that also we do very regularly. Van Wheely meta-analysis says that HMG and FSH recombinant are equally good in PCOS. Okay.
Yeah.
So the only place to use recombinant FSH in PCOS is like if the patient is affording, or if the patient is going for IVF, where you want an increased cumulative pregnancy rate, so you need more number of eggs or more number of M2s. That is the only patient where I go for recombinant. Otherwise, I'm good with everything.
Absolutely. So, there was a thought earlier that because the PCOS patients are LH hypersecretors, we should not give HMG in them and we should restrict ourselves to FSH, either urinary or recombinant. But that thought has gone away now, and we know that HMG works very well with them. And of course, what you talked about, that is very important. The counseling which goes with when you are giving gonadotropin, this is so very important, that first of all you have to tell them the cost of intervention. That what Dr. Rashmi Sharma was also discussing, that sometimes when you do a cost analysis, IVF might appear more, and especially along with the risk. But of course, it depends from practice, it differs from practice to practice. Then we should remember that certain expertise is required for the use of intervention for ovulation induction. One has to know how to play with gonadotropins, and the degree of intensive ultrasound monitoring is required. A low dose step up gonadotropin protocol, which you said, and implications of potential multiple pregnancy. This is so very important, especially suppose you have a patient who already has a child, not at all willing for twins. You have to remember that if you are giving gonadotropins, you are predisposing to multiple pregnancy, and there is no difference in clinical efficacy of the available gonadotropin. But what is most important is that when you are using gonadotropin, the best clinical practice to avoid multiple pregnancy, you have to cancel cycle when there are more than a total of 2 follicles greater than 14 millimeter. And this has come in the evidence, and this is so important that is why sometimes it becomes very dicey to give gonadotropins. But of course, in patients who are resistant to clomiphene or letrozole, we do resort to gonadotropin in some patients. So now coming to again to Dr. Dolly Mehra, because she was talking about laparoscopic ovarian drilling. Dr. Dolly, she said, in which patients do you consider, Dr. Dolly, laparoscopic ovarian drilling?
Basically, lean PCOS and patients where in the LH is raised, I would prefer going for ovarian drilling. And also in patients wherein, the ovaries are really enlarged.
Okay, so ovarian drilling now. I would like to ask the public sector, consultants, Dr. Kiran and Dr. Bindu Bajaj. Ma'am, are you taking up
We
patients
are
for
not doing now that.
only for ovarian drilling and nothing else? Are you taking up?
We have not done ovarian drilling for quite some time now. I mean, we have added IVF facility, so we rather let the patient go in for IVF than do ovarian drilling. Unless the patient is completely, typically A type, where she cannot afford IVF,
And Dr. Kiran Agarwal, ma'am?
If for some other reason you're doing a laparoscopy, you've evaluated everything, for some reason you're doing a lapro, maybe with the consent if you already know that she has a bulky ovaries, but outrightly going on for laparoscopic ovarian drilling, I think all of us are referring the patients for IVF after the basic protocols are over.
Yeah, so absolutely. Now we are also doing ovarian drilling only in the setup where you have to look at the tubes. Maybe the tubes are blocked, and you have to do that part also. You have to look for cannulation or something. Then you do a drilling along with that. So in next cycle in this patient, so we decided to give gonadotropins. We give FSH 75 for 7 days, no response. Then we increased to 100 unit because this was a recombinant for 5 days, no response. Then 150 for 5 days, no response. And then we increased to even 225, no response. So basically this lady who did not respond to letrozole, she, after lifestyle intervention, metformin and everything, she failed to respond to gonadotropin also. So, Dr. Rashmi, how will you now proceed with her? How will you, approach her?
So
This is a obese girl herself.
Yeah. So that's the thing, with the kind of gonadotropin stimulation, when we are starting with the low doses, so many times we might end up having no follicle at all. So in that case, yes, now again, I would try to convince her for IVF so that we can start with a higher dose of gonadotropins and then see whether she responds or not, starting from day 2 or day 3.
So would you, what dose, if you take her up for IVF, what dose will you start with?
So now that we are no longer worried about OHSS at all, and now that we have seen that she even failed with 225, I would start her at 300 IU straight away.
Okay.
And maybe step down later if I feel that she might have too many follicles. But otherwise also, if there are too many follicles, we are not worried about OHSS. So it's okay.
Okay. Any other panelist has to add anything to this patient now that she is gonadotropin resistant? Dr. Kiran, Dr. Bindu, ma'am.
Dr. Neeti, I told you earlier also that perhaps she'll need some bit of dexamethasone right from for a whole cycle to reduce. We should be sure that prolactin I'm sure you have ruled out any hypothyroidism and hyperprotectinemia.
Hypothyroidism, prolactin has been ruled out.
So we have a kind of a thesis. We have done it, and our patient respond reasonably well when we put them on 2 milligram dexamethasone for 10 days, starting from 7th day till or giving starting from the 3rd day onwards for 10 days in the early follicular phase. They do respond, these patients.
Okay, ma'am. So, I would like to add certain investigations here. So, I don't know, because sometimes we have just seen the AMH and we have not seen a baseline FSH in these patients. And we had some patients in the past which we dealt with where the FSH was also high baseline along with high AMH. Now, these are patients who are FSH receptor resistant. So it's very surprising, like AMH of say 6 nanogram per ml with a FSH of 12 or 13. So in these patients, as Dr. Rashmi said, that higher dose of gonadotropin may work. Okay. Then baseline LH. Suppose the baseline LH is high with a normal FSH, which we accept in a PCOS patient. But suppose this patient is also resistant, one can think of bringing down LH, because otherwise there is no role of bringing down LH. But in these patients, we may think of bringing down LH. So role of pre-treatment with OC pills may be there. Then doing a 17 hydroxyprogesterone to rule out congenital adrenal hyperplasia. So here is where Dr. Bindu is talking about that there are patients who are basically congenital adrenal hyperplasia, and you kind of keep on treating them like PCOS because they are hirsute, they have irregular cycles, they have same actually phenotype, the congenital adrenal hyperplasia and PCOS. And if your PCOS fails to respond, go back, check a 17 hydroxyprogesterone, and you might be dealing with a case of congenital adrenal hyperplasia. And here there could be an established role of steroids. The same way serum DHEAS may be done, and if serum DHEAS is high, because we know that it is coming only from adrenal, and the way to control adrenal is by giving dexamethasone, so that can be done. And receptor polymorphism, if it is there, it is there. There would be a very, very, very small subset of patients who will not respond to anything, and they may have a very high MH PCO ovaries, but they just don't respond. So there will be a very small subset of patients, and they might even end up with a donor egg one day. But of course we should try everything before telling them to go for any such third party reproduction. So Dr. Bindu ma'am was talking about, so she has talked a lot about dexamethasone resistant PCOS. So I also found some articles where there was a role of giving steroids even in patients who have a normal 17 hydroxyprogesterone acetate or normal serum DHEAS level. So these are not congenital adrenal hyperplasia, but giving a small dose of dexamethasone, which Dr. Bindu has been talking about, may help in these patients of resistant polycystic ovarian syndrome. Now, is there a role? Suppose, because we were talking about that we have to cancel the cycle if the follicles, there are 2 follicles more than 14 mm. And suppose there are 3-4 follicles. Is there a role of giving a agonist trigger to prevent OHSs in these patients, Dr. Rashmi?
So not for preventing OHSS. See, because if there are more than 2 follicles, I would cancel the IUI, because we are not only worried about the OHSS, we are more worried about multiple pregnancy. But as such, GnRH agonist trigger works very well if your number of follicles are not more. So this thing that agonist trigger leads to luteal phase deficiency, it works only when there are too many follicles. Otherwise, GnRH agonist trigger leads to both LH and FSH surge internal, which leads to better maturity of the oocytes. And there is evidence in the literature. So in my practice, I have used a lot of GnRH agonist trigger in IUIs. Otherwise also, in fact, have published a paper also, HCG versus GnRH agonist trigger in the Journal of Human Reproduction. So I'm very much fond of using the GnRH agonist trigger in IUI cycles.
Okay. Anyone
Not
else
for
has
prevention, but for better pregnancy rates.
Yeah. I understood. So Dr. Rashmi Sharma is very clear about this, that she is giving, when she is giving GnRH agonist trigger, she is giving agonist trigger to get that slight FSH, peak also, which comes with GnRH agonist trigger along with LH surge. But please don't consider it giving for preventing OHSs, because it might prevent OHSs, but it will not prevent multiple pregnancy. So if your patient have 4 or 5 follicles, she may come back with triplet, or quadruplet or pentaplet. It will not prevent that. So agonist trigger not for prevention of OHSs. Anyone else has any other?
OHSS will not be prevented by agonist trigger.
Of course. And what complication do you anticipate during pregnancy in PCOS? Anybody can take this question.
PCOS, with the history of PCOS, pregnancy is a high risk pregnancy.
Yeah.
Previously, we used to say that ART pregnancy are similar to normal pregnancy, but I think so now it's well established they are a high risk pregnancy. Especially if a patient has history of PCOS, we should counsel them that they have a higher risk. If there is obesity, also then even more higher risk are there. They may have early abortions, and then later on they may have preterm labor, PROM, hypertension, GDM. So all these high risk factors are associated with a PCOS pregnancy. And if it is multiple pregnancy, then we have to be very attentive.
Thank you so much. Thank you. It was a very nice interactive sessions with learned panelists. Thank you so much.
Acha, one point I would add, because of hyperandrogenemia and PCOS, they have cervical shortening as well. So that is another risk factor there. Thank you. I think so we are running short of time.
Thank you so much.
Point to ponder. Point to ponder.
Thank you, Dr. Piki and Dr. Niti, for a very great panel discussion. Now, we have got very little time with us, so let's move on to the third session. Can we have the CVs, Megha? The next topic is early pregnancy bleeding, interpretation and management. So it's my proud privilege. Megha, I need to have CV of Dr. Shashibala Bhonsle ma'am and Dr. It's my proud privilege to invite chairpersons for the session, Dr. Shashibala Bhonsle. She's a consultant gynecologist in Public Health and Family Welfare Department of MP government. Currently, she's President Gwalior Menopause Society with so many awards and honors to her credit. Second, we welcome you, ma'am. Our second chairperson is Dr. Brajbala Tiwari, madam. She is a highly decorated gynecologist and infertility specialist of Indore. Currently, she is chairperson Foxy Environmental Health Committee 2025 to 2027, Secretary MP ISAR, past President Indore Obs and Gynae Society, and an eminent faculty in various national and international conferences. We welcome you, ma'am. Now I request Dr. Shashibala, madam, to kindly introduce our speaker, Dr. Megha Kansara. Dr. Neha Saraf is not there, I think. Yeah.
Yeah, she is in an emergency. Thank you, Deepa, and thank you for the opportunity to chair with Dr. Brajbala.
Thank you. Thank you. Good evening.
Now, I would like to introduce Dr. Megha Kansara, our speaker for the day. She's MS, FAMS postdoctoral fellowship in minimally invasive pregnancy. Can I have the CV of Dr. Kansara, please?
Yes, ma'am.
Yes, yeah. Now, she present designation, she is right now consultant IVF and endoscopic unit, ESIC and PGSR Medical College, Vasai Darapura, New Delhi. And she's an executive member of NACHI 2022, invited as chairperson in laparoscopic workshop organized by VMCPC in Safdarjung Hospital in just latest 25, executive life member of IAG, invited as faculty in IAG, very active member, invited as faculty in Jaipur this year only. So she's a life member of NACHI and AOGD, ex-assistant professor LHMC, and she's an outreach committee member of NACHION 2022. She's won second prize at the quiz competition on topic of medical disorders in pregnancy and NACHI annual conference at Lady Harding. So that means she's such an active member of Delhi. Third prize is in quiz and a prize winner all the time. So she loves quizzing, I suppose. Chapter conference. So over to you, our speaker for the day.
Thank you, ma'am.
Yes,
Thank you so much.
Over to you.
Thank you so much, ma'am.
Yeah. Can you take can we have your video? Where are you?
Yes, ma'am.
Yes, that's it. Thank you.
So I'll be talking about early pregnancy bleeding, its interpretation and management. Bleeding in early pregnancy is very common. It's 20 to 30% of the cases. So it is important to identify the cause. So most of the time it can be physiological, So we have to reassure the patient. In case it is pathological, early diagnosis and management are essential. So we need to differentiate between the physiological and pathological causes of early pregnancy bleeding. So when we talk about the benign causes, here comes first implantation bleeding, bleeding because of cervical irritation. In pathological causes, abortions, all the type of abortion like threatened abortion, inevitable abortion, missed abortion, ectopic pregnancy, molar pregnancy, subchorionic hemorrhage, and cervical local lesions like polyp, cervicitis, or trauma. So out of all the causes of early pregnancy bleeding, most common is threatened abortion, 30 to 50%. All other causes like implantation bleeding, ectopic pregnancy, miscarriage, other are the least common cause, molar pregnancy and all. So what is implantation bleeding? Implantation bleeding basically occurs when the fertilized egg, that is a blastocyst, try to embed in the endometrium, the thick endometrium of pregnancy, which is disrupting the tiny blood vessels. So it causes light spotting. What is typical about implantation bleeding is it occurs 10 to 14 days after the conception. So when we evaluate a patient of early pregnancy bleeding, it starts with taking history. So first we have to take a history of her last menstrual period. So it will tell about whether the patient is pregnant or not pregnant. So then the quantity and the quality of bleeding. Suppose if it's dark is brown in color, it can be implantation bleeding. If it is dark red in color with passage of clots, pain, it can be any type of abortion. A detailed obstetric history has to be taken. History of sexual history, trauma history has to be taken. The risk factors like use of any intrauterine contraceptive devices, previous history of PID. Nowadays we are doing more of ART, so IVF pregnancy. This detailed history has to be taken. So moving on to the diagnosis, the first line diagnosis made by transvaginal ultrasound. Ultrasound will tell you about whether the pregnancy is intrauterine or it is extrauterine. If it is intrauterine, it is failed, it is threatened abortion or any other abortion. Second is serial beta HCG. So it will take about the pregnancy, whether it is the beta HCG is within the discriminatory zone, that is 1500 or less or more. So that will make the diagnosis. Other blood test, basic and progesterone, not always needed, but in case the progesterone level, the serum progesterone levels are less than 9, so the negative predictive value of not being pregnant is high. So ultrasound interpretation, if the uterus is empty and the beta HCG levels are more than 1500, there is a possibility of either ectopic pregnancy or early intrauterine pregnancy. If there is a gestational sac, so pregnancy is of unknown viability. We don't know the viability. So follow-up scan has to be done. If the fetal pole is present with cardiac activity, then it is a viable pregnancy. If there is no cardiac activity, even if the CRL has reached 7 mm or if the mean sac diameter is more than 25 mm, it is labeled as missed abortion. There are certain risk factors for the abortion. Most common is idiopathic, then chromosomal causes needs evaluation, toxic exposure. Nowadays, the pregnancy is with advancing age, so we need out the risk of chromosomal abnormality in advanced pregnancies are high, and placental problems. So first I'll talk about threatened abortion. Threatened abortion when the bleeding is occurring with closed cervix. There is a viable intrauterine pregnancy. Bleeding is not too much. It is slight, mild red in color. Pain is usually absent or can be slight. So management is rest and observation. So what is the literature of progesterone supplementation? So literature says that progesterone supplementation in a pregnant woman with threatened abortion or a recurrent abortion, they have variable results. Like it can decrease the chances or decrease the chances of miscarriages. But most of the studies has said that there is no increase in the live birth rate. There was another RCT which says that between two groups, when we give a placebo or we give progesterone in cases of threatened abortion, the live birth rates are comparable. Although the chances of miscarriage in the women who are having the progesterone is less. When we talk about the route of progesterone, oral versus vaginal, oral progesterone has maximum compliance rate. And also the oral progesterone has efficacy higher as compared to the vaginal progesterone. Second is inevitable or incomplete abortion. When the bleeding is heavy with open cervix, it is inevitable abortion. Management is usually surgical or medical, depending upon the condition of the patient. Missed abortion, there is no symptoms, patient is not having any bleeding, no pain, but fetal cardiac activity is absent. So in that case, we need to evacuate either medically or surgically, that is DNC. Molar pregnancy, there is an abnormal trophoblastic tissue which causes heavy bleeding, amenorrhea, and pain. On ultrasound, there is a typical picture of snowstorm appearance of the products of conception. And the treatment is evacuation and follow up with serial beta SCGs. So this is the table which is showing in short the clinical features, the ultrasound finding, and management. When we talk about early pregnancy bleeding, apart from abortion, ectopes pregnancy is something which is the leading cause of maternal mortality and morbidity. So we need to identify the ectopic pregnancy. Its earlier management will save the life of patient. So there are different type of ectopic pregnancies. Implantation outside the uterus is ectopic pregnancy. So diagnosis is made by beta SCG and transvaginal ultrasound. There are some risk factors for ectopic pregnancy. If the patient is having prior history of ectopic pregnancy, if the patient is having pelvic infections, history of PID, STDs, tuberculosis, self-ingitis, it increases the risk of ectopic pregnancy. Prior history of any tubal surgeries also increases the risk of ectopic pregnancy. Endometriosis, pelvic scar because of pelvic adhesion, they distort the tube-ovarian relationship, leading to increase in the incidence of ectopic pregnancy. Any congenital abnormality of the tube is also a risk factor for ectopic pregnancy. Ectopic pregnancy accounts for 10 to 15% of all the maternal death. So because of the high rate of mortality, that is 1 in 2,500 cases, we need an earlier evaluation, diagnosis, and management. This is a picture which is showing a adnexal complex mass with a thick echogenic wall and a ring of fire appearance typical of ectopic pregnancy on Doppler. So there are 3 treatment options. Either we do expectant management of ectopic or medical management or surgical management. Surgery is always indicated in the patients who are hemodynamically unstable in cases of adnexal mass of more than 35 mm size, if the cardiac activity is present, if the patient is showing any signs of rupture, ectopic, or if the serum beta SCG levels are more than 500. In patients who are not suitable for medical therapy or are not willing for post-medical therapy follow-up, in that cases, surgery is also indicated. In patients or contraindication of methotrexate, surgery is indicated, or failed medical therapy, or in case of heterotropic pregnancy, although the incidence of heterotropic pregnancy is less, but in case if it is a viable intrauterine pregnancy, we always go for surgical management. Criteria for expectant management in case of ectopic pregnancy, the serum beta SCG levels are less, that is less than 1,000, or are declining, that is less than 1,500. In that patients, we can go for expectant management. In expectant management, we just follow up the beta SCG levels and do nothing, no medical management. The woman is clinically stable or pain-free, or the size of ectopic is less than 35 mm with no cardiac activity, and the patients who are complying for follow-up. This is the flowchart diagram showing the management of ectopic pregnancy. Depending upon the vitals of the patient, if she is stable and the size of the adnexal mass is less than 3 centimeter, medical management is used. When we talk about medical management, methotrexate is a drug of choice. It can be given as single dose, multiple dose regimens with leucovorin, depending upon the initial beta SCG level. The success rate of giving the medical management with methotrexate depends upon the initial beta SCG levels. If they are less than 3,000, the chances of success rate is higher as compared to if the initial beta SCG levels are higher. If the patient is stable and the size is between 3 to 5 centimeter, or if the cardiac activity is present, in that case, there is a contraindication, then we do a minimal invasive surgery, that is laparoscopic self-injectomy. In patients who have already undergone self-injectomy of other tube, in that patients, we can opt for self-injostomy or self-injotomy. But again, the chances of ectopic, the recurrence rate is high when we're doing a conservative tubal surgery. If the patient has landed up in shock in emergency, then there is no doubt do a laparotomy and save the life of patient. There are different types of ectopic pregnancies, interstitial and the cornual ectopic pregnancy. Interstitial or cornual ectopic pregnancy is a pregnancy which is present in the interstitial segment of the tube. Diagnosis is made on 3D ultrasound when we talk about the surrounding myometrium. Normally, the gestational sac is surrounded by a myometrium of more than 5 mm. But in case of interstitial ectopic pregnancy, it is not surrounded by a myometrium. So myometrial lining is thin. Cervical ectopic pregnancy, when the pregnancy is situated between the internal and the external os in the cervix, it is considered as cervical ectopic pregnancy. Caesarean scar ectopic pregnancy, when pregnancy is present at scar site, it is caesarean scar ectopic. There are two types of caesarean scar ectopic, type 1 and type 2. Type 1 is endogenic, type 2 is exogenic. Endogenic means if the sac or the pregnancy grows inside the endometrial cavity and it causes more of bleeding. And exogenic is type 2, when the sac or the pregnancy will grow towards the bladder. So it will grow out. So it is type 2. Now, this is the table which is showing the management, the clinical presentation of different type of ectopic pregnancies. In interstitial pregnancy, we have to do surgery. Methotrexate, earlier it was considered, but now because the chances of rupture rate is, there is a delayed rupture, but rupture occurs at 8 to 6 weeks because of the myometrial tissue. But patient goes into shock in minutes. So surgical management is considered. In cervical ectopic pregnancy, if it is endogenic, we'll go for hysteroscopy. Again, hysteroscopic resection, many studies have said that if the size of the ectopic pregnancy is less than 3 mm and if the patient is not bleeding, then we can opt for hysteroscopic. Otherwise, laparoscopic management can be done in case if it is growing towards the bladder. Ovarian, in case of ovarian pregnancy, the treatment is surgical resection of the ovarian tissue, or it can be done along with oophorectomy. In abdominal ectopic pregnancy, we have to do a laparotomy with surgical removal of the ectopic mass and the placental tissue. In case of caesarean scar pregnancy, methotrexate is now considered as drug of choice. Again, for a small size, if the initial beta HCG levels are less, we can consider methotrexate. Otherwise, if the patient has come in shock in emergency, surgical excision has to be done. Or if the initial beta HCG levels are higher, then we always plan for surgical excision. In case of heterotopic pregnancy, surgical removal of ectopic, just preserving the intrauterine pregnancy, is the method of choice. This is the flow chart which is showing the management of patient who has come with bleeding at POG of less than 12 weeks. So first we'll see the clinical condition of the patient. If the patient is hemodynamically unstable, we have to resuscitate her, do surgery. If it is non-obstetrical cause, we'll treat accordingly. If there are product of conceptions which are seen on examination, that is os is open, she is bleeding, we'll do an immediate suction evacuation as we label the patient as incomplete abortion. If the patient is stable and there are no product of conception, then we identify the cause of bleeding doing on the basis of transvaginal ultrasound and beta HCG levels. So if it is a viable pregnancy, it is considered a threatened abortion. We'll conservatively manage the patient. If it is a non-viable pregnancy, we'll discuss the treatment options and either medical or surgical management can be done. If it is an intrauterine viable pregnancy, then we'll repeat the ultrasound. We will repeat the ultrasound after 7 to 14 days. If we have not seen any intrauterine or ectopic pregnancy sac, then we'll label as a pregnancy of unknown location. So depending upon the beta HCG level, we'll discuss the management. If the beta HCG levels are higher than 3000 and patient history is not consistent with having a passage of clot, we'll consider this as a high suspicion of ectopic pregnancy and manage according to that. If the patient has history of passage of clots, then we'll repeat the beta HCG after 48 hours. If the beta HCG levels are less than 50% or increase, then chances of ectopic pregnancy is high. We'll manage accordingly. And if the beta HCG level is decrease is more than 50%, then it can be a resolving pregnancy of unknown origin or an ectopic pregnancy, or early intrauterine pregnancy. If the beta HCG levels are less than 3000, we'll repeat the beta HCG levels in 48 hours. So we'll manage accordingly. If the repeat beta HCG levels are more than, the decrease is more than 50%, then we label as suggesting resolving of the pregnancy of unknown location. Then we need not to do anything. If the beta HCG levels are decreased but less than 50% or has increased less than 40%, then we suggest that early pregnancy loss has occurred or ectopic pregnancy. Then we'll monitor the patient with the serial beta HCG levels and transvaginal ultrasound. If the repeat beta HCG levels are more than 40%, there is a viable pregnancy intrauterine. So, or it can be an early pregnancy loss. To bind up the. Okay, ma'am. Just 2 slides are less. Yeah, okay. Counseling and follow-up is important. Provide emotional support, educate on the warning signs, monitor the recovery of the patient, and discuss the future pregnancy plans. So to conclude, early pregnancy bleeding needs timely attention. Aim is to protect the maternal health and when possible, preserve the pregnancy. Prompt evaluation using beta HCG level and history and ultrasound has to be made. Then manage according to the cause, based on the cause, and provide follow-up and emotional support to patient. Thank you, ma'am. Now I request Brajbala Tiwari, madam, for her expert comments.
Thank you, Dr. Megha. It was nice elaborated talk because this early pregnancy bleeding is really very sensitive issue, and whenever couple comes with positive pregnancy and 6 weeks they are getting sonography and cardiac activities there, and suddenly they start bleeding. It's really emotional issue for them, but simultaneously challenging. Whether we should reassure them it is going well, or again we have to so nicely elaborated all the flow chart, and we have to rule out particularly scar pregnancy. Nowadays it is increasing, so we have to careful in looking. It's correct topic.
Yes.
So for that we have to look. So it was very well covered.
Recently there was a reported pregnancy in the liver. They had seen
Yes,
in the
ma'am.
liver.
Primary hepatic
It was a
pregnancy.
primary hepatic pregnancy. So how will we at loss? What to do at that time?
Yes, ma'am. That is
That
again
is so challenging again. No?
challenging and
Yes,
To be
yes, yes.
operated with the help of
Seniors.
the surgeons. We have
Yeah.
had such a pregnancy in Harding,
Okay.
and it was
Okay.
a real difficult thing.
Ha. So
um,
you
that-
can unpredictable. Pregnancy is really unpredictable.
Human reproduction is very inefficient because biological, biochemical pregnancy is there, but live birth rate
Yeah.
may be.
But to
So we
conceive is
have to
difficult, and to
counsel the
continue
patient.
is equally difficult becoming nowadays. Yes.
exactly,
It was
ma'am. Exactly.
Thank you,
very well
Deepa,
presented.
Dr.
Yes.
Picky, and
Thank
Dr.
you.
Rakhi for making MP the part of
Part
AOGD.
of.
Thank you,
Yeah.
Brajbala. It is nice to meet you here
Yes,
again.
ma'am.
Yeah.
And Dr. Shashibala, it's nice
Yeah,
to
We
yeah.
have Dr. Aditi Rathore also. She couldn't join for the panel. Dr. Aditi, you want to add something? Dr. Aditi Rathore from Ratnam.
Yeah, Dr. Aditi.
Good evening,
There she
everyone.
is.
I'm so sorry, ma'am. Actually, I had to leave in
Hello,
between.
Dr.
There was
Aditi.
a
No
case.
need to apologize. We are happy to see you here.
No, it was a very interesting talk which started with Dr. Rakhi Singh, ma'am's wo. And all the best to all of you. All my friends I can see there up. So Deepa ma'am, Shweta, Pam ma'am, and Rakhi
Yeah.
ma'am. May you all emerge winners and, you know.
AOGD
Thank you.
and Gwalior and MP are like siblings. We are nearest next to you.
Yes,
So
ma'am. Yes, ma'am.
AOGD is ours.
We all are the part of extended family only.
Extended family, that's the word. So thank
So,
you so
Dr.
much.
Aditi,
It was
you can
nice.
give
Thank you.
vote of
Yeah.
thanks at the end.
Okay.
Thank everyone for the conference.
Yeah.
Yes.
Actually, we are quite very late. I'm very thankful to all my students, Dr. Reena Yadav, madam, Dr. Pankaj Talwar, sir, Dr. Professor Shweta Mittal, ma'am, Dr. Ratna Vishwas, madam, Dr. Abhyande Verma, sir, and all the esteemed chairpersons, Dr. Shweta Gupta, Dr. Jyoti Bhaskar, Dr. Parul Garg, Dr. Deepika Verma, Dr. Kiran Agarwal, madam, Dr. Rashmi Sharma, Dr. Brajbala Tiwari, ma'am, Dr. Shashi Bhosle, ma'am, Dr. Bindu Bajaj, Dr. Dolly Mehra, Dr. Shweta Jha, Dr. Aditi, Dr. Neha Sraf, and our esteemed speakers, Dr. Rekha Singh, Dr. Picky, Dr. Niti, and Dr. Megha.
for their valuable time and insightful talks. I hope our audience must have definitely benefited from these wonderful sessions, and we hope to continue to serve better with many more interesting topics. Very special thanks to the Clarinet and IT person Atul for all the technical support, and kindly bless me with your precious vote at ICOG elections in September 1st to 10th September. Thank you.
Yes.
Best wishes, my wishes to everyone. Dr.
Thank
Shashikala,
you.
Rita,
And I
Deepa.
have one more connection to Delhi. All my friends, Ajay Lekhi, this
Yes, ma'am.
Dams Wala, Bhagi, all they're my classmates. Anil Safaya, Utsuk Datta. So all Sushma
Okay,
Didi is
okay.
there, Sushma, Dikit,
Ma'am,
Rupam. So all from Gwalior.
they are cream in Delhi, like they are very,
Yeah,
very senior.
Neelam is my friend. Yeah, Neelam Lekhi and all. Yeah. So we are quite seniors actually.
Dr. Shashimania, you are also our friend now. So
Yeah,
wishing you,
yes.
we are
No,
all
no, no.
friends here, so
Yes, thank you
wishing
so
you all the
much.
best to all the 4 contestants.
Thank you,
Okay.
thank you.
Ma'am,
Bye-bye.
thank you.
Thanks to all the faculty for being there and all the delegates to post the questions and for making this a success. Thank you very much.
Yeah, and
Thank you.
Deepa had a role to play. Thank you, Deepa.
Thank you, Dr.
Thank
Deepa.
you.
Thank you, Dr. Piki.
Yes.
Thank
Yes.
Thank you,
you.
Dr. Piki.
Dr. Picky, your name is so sweet.
I know.
Picky. I
Yes.
know. I thought Palm is sounding something different. Picky is also different. Okay then. See you.
Okay.
Bye.